Thank you very much for the very kind introduction. I'll be talking today about the practical guidance for implementing long-acting antiretroviral therapy in clinic. So the outline of my talk today will be largely the need for long-acting antiretroviral therapy with a focus on cabotegravir and rilpivirine, a summary of the initial long-acting cabotegravir rilpivirine phase 3 clinical trial data, clinical and practical considerations of long-acting ARV implementation, and to end off with a few updates from CROI from this year. So what's the current status of long-acting antiretroviral therapy? Well, furthest in development and commercial availability, of course, is long-acting cabotegravir and rilpivirine, but of course we have lenacapavir and other long-acting antiretroviral therapy. With respect to long-acting cabotegravir and rilpivirine, this has been licensed to be given intramuscularly every 4-8 weeks and largely in virologically suppressed patients. Although we'll be able to see later on towards the end of the presentation that there's increasing role of these drugs or medications in patients with viremia. So where do long-acting antiretroviral regimens fill the gap? Well, there are plenty of opportunities, and certainly there's a need where there's less frequent dosing and avoidance of pill fatigue, where there's a need to increase choice for patients and providers. Particularly in qualitative studies of long-acting antiretroviral therapy, avoidance of HIV-related stigma and the daily reminder of HIV provides an important reason why a considerable number of people living with HIV would want to switch to long-acting antiretroviral therapy. It addresses suboptimal adherence. It's convenient for work and travel reasons, and certainly where there's a biological or strong medical need, for example, in patients with malabsorption and dysphagia. It eliminates gut-based drug-drug interactions and food effects, and it offers the possibility of co-formulation with other long-acting antiretroviral drugs. However, there are cost and resource considerations, and this is a particular concern within the Asia-Pacific setting, and the need for additional clinic visits every 1 to 2 months. The injections at this moment cannot be self-administered, and of course, the most common side effects are injection site reactions. Of course, there are knowledge gaps in certain vulnerable groups, but this is an area which is becoming where the data gaps are being filled, for example, in adolescents and resource poor settings, particularly from CROI of this year. And there are concerns around how to manage missed doses, managing drug-drug interactions, and the majority of treatment trials so far have mainly included patients with virological suppression. So what do the initial phase 3 clinical trials in long-acting cabotegravir and rilpivirine have shown so far? Well, the ATLAS and FLAIR studies have found that monthly long-acting cabotegravir and rilpivirine injections to be non-inferior to oral antiretroviral therapy up to 96 weeks in the ATLAS study and 124 weeks in the FLAIR studies. In the ATLAS 2M studies showed that 2 monthly long-acting cabotegravir and rilpivirine is non-inferior to 1 monthly long-acting cabotegravir and rilpivirine up to 3 years of follow-up. However, there was a small but increased risk of virological failure, which occurred in 2% of patients with emergent 2-class resistance with the 2 monthly regimen compared to less than 1% in the monthly regimen. This occurred despite perfect adherence with no delayed injections. The FLAIR extension study showed that patients who were virologically suppressed on oral antiretroviral therapy who switched to long-acting cabotegravir and rilpivirine without an oral lead-in had similar virological suppression rates to those who switched with an oral lead-in. So long-acting cabotegravir and rilpivirine really represents the first complete long-acting HIV regimen, with initial approvals in March 2020 in Canada and subsequently in Europe and United States, both for the monthly and the 2 monthly regimen as well. And in 2022 in the US, the 4-week oral lead-in is now optional. This regimen is available either co-packed as Carboneva or single packs as Vocabria, which is cabotegravir long-acting, or Recambis, long-acting rilpivirine. Now, within China itself, since October 2023, China's National Medical Products Administration received approval for both Vocabria, cabotegravir used in combination with rilpivirine. But this is just to remember that this was not the first long-acting injectable that was introduced in China. China, in fact, was one of the first countries to approve a long-acting injectable. This one is called albuterol, and it's from Frontier Biotech, and it's given by once-weekly injection. However, it's given intravenously. There are clinical guidelines regarding the clinical eligibility, so for who cabotegravir and rilpivirine might be suitable, and looking specifically at largely the European and the American guidelines. So BIVA, patients who are eligible for long-acting cabotegravir and rilpivirine had to be virally suppressed for at least 6 months, with no treatment failure history or no known resistance to either cabotegravir or rilpivirine. They had to have a BMI of less than 30 and a non-A1 or A6 subtype if baseline resistance was unavailable. They also had to commit to 2 monthly attendance for injections and accept the risk of virological failure and resistance despite complete adherence. In terms of monitoring, subjected to 2 monthly HIV viral loads, and they do not need it, and patients who were considered eligible did not need hepatitis B treatment or prevention. Looking at risk factors for virological failure with long-acting cabotegravir and rilpivirine, a post-hoc analysis of week 48 data from Atlas-FLAIR and the Atlas-2M study showed that the virological failure was about 1.25%, and that the predictors of virological failure were mainly baseline proviral rilpivirine resistance-associated mutations, HIV subtype A1 or A6, and low rilpivirine levels at week 8. And also a BMI greater than 30, although the odds ratio was less. You needed a combination of 2 or more baseline risk factors for increased risk of virological failure, and the 2 monthly dosing was not a significant factor. An expanded multivariate analysis of virological failure from these studies showed that the most significant predictive factors for virological failure were baseline rilpivirine resistance associated mutations and a HIV subtype A6A1. Looking at practical considerations when using long-acting cabotegravir and rilpivirine, these initiation injection kits are often co-packed with single-dose vials, 2 syringes, 2 labels, and 2 needles. In the 2 monthly schedule, it's shown there. For the 2 monthly dosing schedule, you initiate the injections of cabotegravir 600 milligrams and rilpivirine 900 milligrams monthly for the first 2 months, and then every 2 months thereafter at that same dose. For the monthly dosing schedule, you use 600 milligrams cabotegravir and 900 milligrams of rilpivirine. And then at month 2 and beyond, you use a lower dose of cabotegravir, 400 milligrams, and a lower dose of rilpivirine at 600 milligrams. You inject it at 2 separate gluteal sites, opposite sites, or 2 centimeters apart, essentially. Storage and medication supply considerations. The kits will generally arrive by cold chain supply. The rilpivirine needs to be stored in a refrigerator at -2 to 8 degrees Celsius. Cabotegravir does not require refrigeration, but it's often co-packaged in the same box with rilpivirine, requiring the entire box to be refrigerated. It needs to be removed 15 minutes from the refrigerator to reach room temperature pre-administration, and it cannot be refrigerated again. When it comes to administration, it's currently requires to be administered by a healthcare professional. There's an optional oral lead-in dosing for 1 month, and you really need to consider the BMI when selecting needle length. We use generally a 23 gauge, 1.5 inch needle is recommended, but you're advised to use a 2 inch, 21 gauge needle, which is not included in the box if your BMI is greater than 30 or there's increased fat distribution in hips and the buttocks. In terms of injection training, the ventral gluteal IM injection into the gluteus medius muscle using a Z technique is recommended, as it avoids a lot of the nerves and vessels. It should be given on opposite sides, or when possible, or more than 2 centimeters apart if given on the same side. A dorsal gluteal approach, which is the upper outer quadrant approach, is acceptable if it's preferred, and you need to observe the patient for up to 15 minutes post-administration. Injection site reactions are the most common adverse event which is reported, and is pain or soreness at the site. First injections are generally more painful, and ventral gluteal injections tend to be less painful than dorsal gluteal injections. Very common, 99% of injection site reactions are mostly grade 1 and 2, and the median duration is generally about 3 days. But very few lead to discontinuations, either up to 2 to 3%, and up to 82% resolve within 70 days. Ways of managing this, including using ice packs, non-steroidals or paracetamols, and anticipatory guidance to expect patients and warn patients of this goes a long way. With regards to implementation, nobody doubts the successes and the gaps that long-acting antiretroviral therapy has filled. But there are complex logistics when it comes to implementation and monitoring. And this has been highlighted in a blog by Paul Sachs on HIV and ID observations. The concerns, as mentioned before, with the risk of treatment failure with resistance, even with near-perfect adherence to the regimen. Cost is a major issue, particularly in the Asia-Pacific, and it's like history repeating itself, where access has been largely limited to high-income settings across the Asia-Pacific anyways. For now, injections must be delivered by a healthcare worker, although this might change in the near future. Concerns about frequency of visits, injection site reactions, and limited data in specific vulnerable groups. With respect to in low middle income settings, those who are not suitable for long-acting carbapenem and rilpivirine include those with hepatitis B co-infection, those with TB, those who are pregnant, and those with resistance to either drug in the regimen, and those with prior treatment failure. Although this data, with emerging data, this is changing, and those who are unable to commit to 2 monthly visits. Implementation considerations in low middle income settings include costs, registration, availability of drug, need to screen hepatitis B prior to treatment switch, requirement for baseline resistance testing, and more frequent viral load monitoring, particularly in settings where they're doing this less frequently. Cold chain requirements for long-acting rilpivirine, healthcare provider and system strengthening, and it conflicts with current differentiated service delivery models, which see patients every 6 months now. The need for oral bridging for missed injections, and modeling data have shown that this is likely to be more cost-effective if it targets populations with poor adherence and a viral load greater than 1,000 copies per mil. Lots of implementation data are coming out for long-acting antiretroviral therapy, particularly from the US and high-income settings. And this is a hybrid implementation effectiveness studies across a number of US clinical sites looking at the barriers and facilitators to implementation of long-acting carbapenem and rilpivirine across US clinical sites. And some of the key strategies for successful implementation include good staff communication, teamwork, use of a web-based treatment planner, and some strategies for better patient adherence include communication around the dosing window, using effective appointment reminder systems, and designated staff for appointment tracking. Now, since CROI 2024, there has been interest looking at more vulnerable, looking at different populations, particularly in low and middle income settings. And this was the CARIS trial, which essentially showed that long-acting carbapenem and rilpivirine given every 2 weeks was non-inferior to continued oral antiretroviral therapy in sub-Saharan African sites. This was provided more representation of women, up to 57% of females, with a higher percentage, up to 72% of prior NNRTI regimens. And patients had to be virologically suppressed and were randomized to either long-acting carbapenem or rilpivirine, given every 2 months versus standard of care, most of whom were on tenofovir, lamivudine, and dolutegravir. there were equal and very high virological suppression rates at week 48, and 97% in both arms. But what was of interest essentially showed that on archived proviral DNA analysis on baseline samples of peripheral blood mononuclear cells, that this viral suppression rates occurred despite very high rates of subtype A, 56%, and relatively high rates of rilpivirine and cabotegravir resistance up to 10%. Also of interest is looking at patients who were viremia at baseline, or patients who had poor viral response or were lost to follow-up after having been on 6 months on ART with non-adherence. And so this was a population of interest. This was studied in the Latitude study, and for them to be randomized either to the long-acting cabotegravir rilpivirine arm given every 4 weeks versus standard of care oral antiretroviral therapy, they had to undergo an initial step of taking standard of care oral antiretroviral therapy with strong adherence support and conditional economic incentives, and had to achieve viral suppression before they were randomized to either arm. But what was of interest, of course, was that the long-acting cabotegravir and rilpivirine arm demonstrated superiority compared to the standard of care oral antiretroviral therapy arm, both in the secondary outcomes of virological failure and treatment-related failure. So demonstrating that even patients with viremia could be considered for long-acting cabotegravir and rilpivirine. And this was reflected in the updated guidelines of the IS-USA guidelines, which stated that when supported by intensive follow-up and case management services, injectable cabotegravir and rilpivirine may be considered for people with viremia who meet the criteria below when no other treatment options are effective due to the patient's inability to take oral ART. So in circumstances where they're unable to take ART consistently, despite extensive efforts and clinical support, when there's high risk of HIV disease progression, and when the virus is susceptible to both cabotegravir and rilpivirine. With that, I'd like to thank you very much and acknowledge the various people on my slide. Thank you very much.